Good morning, everyone, and welcome to our first virtual town hall meeting. My name is Kelly Richards, and I am the State Long-Term Care Ombudsman. This event will be recorded, so if there's anyone that needs to jump off or misses a portion of it, we will be recording this, and we will post it on our website. At the Ombudsman program, we advocate for residents who live in long-term care facilities, and we ensure that they are aware of their rights. We curated this event specifically for residents. So before we begin, I would like to go over some housekeeping issues. We really want to encourage everyone to ask questions, and you can do so by putting your questions in the chat. And if you don't know where the chat is, it's either at the bottom of your screen or at the top of your screen, and there's a little bubble in the middle that says chat, and you can click on that to type your questions in the chat. If you look at the chat right now, we have information in our chat about my contact information, about the Ombudsman website, which includes contact information for your local ombudsman. And also in the chat is our general email address. So if anyone is interested in emailing us to our general email address, feel free to do so. We also ask that you put your zip code in the chat if you could, so we can just get an idea of who's logging in and where everyone is logging in from. There is some additional information that I would like to share with everyone before we get started. We now have a statewide resident and family support council, which is a virtual meeting that occurs every other Tuesday at 3 p.m. And we have a different topic at every meeting, which is of interest to those who live in long-term care facilities. So if you're interested in more information about the Resident and Family Support Council, please email my deputy, Lee Moriarty, and you can find her email address in the chat. Lastly, we have a new Facebook page, and I encourage everyone to go out and like the Illinois Long-Term Care Ombudsman Facebook page. At the end of this hour, we're going to put up a poll with just only 2 questions, and we encourage everyone to participate in the poll before signing off. So now I'm really excited to get this town hall started. I want to first start by introducing our panel members. And our first member is Becky Dragoo, and she is the Deputy Director of the Illinois Department of Public Health, overseeing the Long-Term Care Division of Healthcare Regulations. Becky is also accompanied by Deb Birdsall and Karen Trimberger, who are infection control preventionists, and they have been helping the Illinois Department of Long-Term Care Division throughout the pandemic. Last but not least is Bruce Carmona, and he is a current resident at a long-term care facility. Welcome to all of you, and thank you for your willingness to join this town hall. We hope this is the first of many town hall events. So let's just get started. I'll ask 3 questions of the panelists, and with each question, we would like each of your perspectives. And to our audience members, please feel free to put any questions that you have for the panel members in the chat. Thank you. So our first topic is ombudsmen continue to hear from residents who aren't allowed to have visitors indoors or are only allowed to have visits for a specified amount of time, like 20 or 30 minutes each week, or are required to have their visits supervised by a facility staff member. Becky, can you speak to the residents and their family members listening who are continuing to struggle with isolation due to these restrictive rules?
Good morning, Kelly, and fellow panel members and residents, colleagues. It's a pleasure to join you here today with the Ombudsman. The Ombudsman are truly our partners in the long-term care setting. As resident advocates, we have a close relationship with the Ombudsman. So again, very happy to be here today. With regard to this question and how we continue to hear from residents who aren't allowed to have visitors indoors, I just want to give a brief overview, if I might, about how the Office of Healthcare Regulation looks at complaints concerning visitation and how we move forward to assist residents that might be having difficulties with these issues or facilities that we call are in non-compliance with the regulations. So the Illinois Department of Public Health receives complaints a variety of ways. The vast majority of those come through our central complaint registry, where residents, family members, or those that wish to remain anonymous or others call our complaint registry and say, hey, you know, we're having challenges with regard to visitation. My loved one is in a facility and I'm not able to visit. So I want to register a complaint. So what the department does is that we put that complaint in our system, and depending upon where it is situated in the state, it goes to our regional teams, and a surveyor is scheduled to go to that facility and investigate. Because we work under a partnership agreement with the Centers for Medicare and Medicaid, we have kind of a strict policy that we have to follow with regard to surveying when we look to see if there's deficiencies. So what we're going in to look and see is, has this facility violated any of the residents' rights? Are there deficiencies that we know put them out of compliance with either the federal regulations or the state regulations? So the surveyors would go in and they would do three things when they investigate a complaint about visitation. They're going to observe. They're going to hang around the facility, go to different areas of the facility and see, are residents having visitors in the facility allowing that? And if so, under what circumstances? Are they being allowed privacy? Are they being allowed to conduct visits outdoors, indoors? What type of restrictions does that facility have at the moment? So we know, and Deb and Karen, my colleagues on the phone, can speak to this as well. If there's a serious outbreak in the community, that might affect the visitation. So our surveyors go in, they observe that, they look to see what's going on. They might talk to residents and they might talk to family members and ask, what is your experience? Are you able to have visitors? Or do you have privacy? What type of precautions are taken? Do you have staff on site that are assisting with that? Are the visits scheduled? They're going to look at all those factors when they go in and speak to residents and their families. If your loved one has called, or if you as the individual has called the department to register a complaint, our surveyors will try to reach out for you as well while they're there surveying to find out what your experience has been. And if indeed there's a violation of the regulations. And then the other thing they do is they look at the records. So they're going to look at the facility records to see, are they scheduling visits consistent, with a manner that allows family members to come in. They're also going to look at things like compassionate care. So is this facility allowing individuals to come in and visit with their loved one for compassionate care reasons? And they should always allow that. They should always allow compassionate care visits. Now, there may be a circumstance where a compassionate care visit is allowed for a resident that has COVID positive situation. And in all cases, what they're going to ensure is that visitation is safe and that they are following the best infection control practices. So if we find, when the Department of Public Health goes in, that the facility hasn't done those things, then we have what we call a deficiency. So we know that there's a deficient practice. They haven't allowed visitation in a manner that they should be with respect to the guidance that's come out for long-term care facilities. And then we would cite the facility for that deficiency and follow through with any enforcement activities that the department can initiate in that facility. So that kind of gives a broad answer, but I do want to allow the space and the time for Deb and Karen to speak to those infection control practices and what that might look like when you have visitors to the long-term care setting. So can I shift it to Deb and or Karen for a moment?
Hey, good morning, guys.
Morning.
Thank you so much for your support of your loved ones in congregate care. It's really important. A little bit about me. I've worked in long-term congregate care for about 45 years. And, it's really important to have that support. At any rate, we're all living through a pandemic. This is not normal times. And for the most part, people are trying to do the best they can with the available information. And I'm going to segue right into That's what CDC is doing. CDC is taking the evidence as it comes and they are making adjustments. And the thing that has changed in a major way is the Delta variant. Now, what happens when you have a bunch of unvaccinated people is it allows viruses to continue to spread. And when they do, they adapt, because all viruses need to do is they need to eat, reproduce, and survive. And the way they survive is by readjusting. It's sort of like a padlock where they readjust the codes. And in this situation, the Delta variant is very sneaky. And so what has happened, I was on a phone call yesterday with CDC, and the thing that has changed, the evidence that's coming out, is that pretty much anybody that is positive with Delta variant, whether they be vaccinated or unvaccinated, carry what they call high viral loads. Now, here's the really good thing about getting vaccinated. Please get vaccinated, because what happens is the people that are getting vaccinated are not getting as sick. A majority of the people, and we're talking about millions of people, you may hear about the 100 cases or so, but that's 100, that's like a 1 in a million. I would take that on a lottery ticket any day, it's way better than lottery odds, that the vaccine is going to protect you. But what happens is you still need to use those core components of infection prevention and control, source control, which would be using, some sort of face covering. Depending on what you're working at, depends on what kind you need. Residents need to be, the ones that are available need to be able to wear source control if they can. I understand that there's whole concerns about behaviors and health issues that don't allow it, but we're still focused on those core components of infection prevention and control, which are vaccination, um, source control by using masks or some other sort of respiratory protection. And for your staff, it may also mean eye protection and face protection. Environmental cleaning and disinfecting, hand hygiene. Those are the core components that'll protect you against a whole lot of other viruses too. So when CDC says they are reinstating the recommendation, because they recommend, they have it's guidelines, it's not rules, that you wear masks when you're inside. There's good reason for it. And it relates to how this virus, the virus is the enemy, how this virus is mutating and adapting. And so the more that we can cut down the number of people that get this virus, the less likely it is that it's going to mutate again. I hope that answered. Karen, do you have anything?
Yeah, I'm going to go back to the original couple threads within the original question related to scheduled visits, et cetera. So Deb and I watch the CDC guidance website religiously and look for, of course, from notifications from CMS, et cetera, related to visitations, activities, whatnot throughout long-term care. So we're taking all of that type of guidance and trying to synthesize it and put it in a format that is hopefully clearly understood or presented to across the state. When you mentioned, Kelly, within the question, something about scheduled visits, and my visits are only 15 to 30 minutes. I wanted to sort of address that just a little bit. Early on, when CMS, remember back in March, we closed, nobody could go in the buildings. So we were on lockdown, so to speak. Then as things began to change, their visits became allowed. And at that time, there was a lot of hesitation. And how do we go about this safely to protect our residents? And so yes, there was guidance, and it's still out there on IDPH website that spoke to scheduling visitations. It spoke to knowing who was in the building. It spoke to supervising those visits. The guidance that is getting ready to be released has taken into account vaccination status. Prior to that, we did not have vaccination. And so we are balancing that. And there will be, and we've been encouraging long-term care facilities to relax their scheduling process their length of time of visits, et cetera, on our Friday webinars. We have a Friday webinar with our long-term care facilities that we share guidance and information every week with them. And one of the things that we've been saying is, you know, that was then, now we have had vaccination, we can be a little bit more lax with some things. And so the new guidance will reflect some of that. We have taken out that the visits no longer need to be supervised. They still need to be overseen in the sense of the facility has to know who's in the building and how many people are in the building, but they do not have to be in the room and hover or whatever the word might be to necessarily oversee the visit. But they, you know, again, it's in their buildings, they're four walls, so to speak, and they are responsible for things that occur within the building. So they have to be aware of what's going on to ensure that guidelines are being followed. Are the groups separated? You know, one of the things within that is that if you're a visitor, that you need to be with your loved one, but you should not be commingling with other visitors, other visitors as well as other residents. And so there should, groups of visiting individuals need to be separated by at least 6 feet. So there's all kinds of things that they need to oversee. So that will still be, that language will still be within the new guidance. The scheduling piece we did remove, and so hopefully that'll take out that 15, 30-minute type. But again, remember early on, that had to be in place because people were newly coming back into the buildings. We wanted everyone to have access to their loved one and be able to get into the building, right? So if one person came and monopolized the entire schedule, then everybody else couldn't see their loved ones. So that was the rationale for the visit, the time slot, so to speak. So that everybody had an opportunity to have a visitor. And then much of what Becky said and Deb said, I would concur with, and hopefully that answered the first couple elements that Kelly mentioned regarding scheduling, et cetera.
Sorry, I put myself on mute. Thank you very much, Karen. I think that did answer the question. And thank you, Becky and Deb. What I wanted to do next is to ask a follow-up question to Deb and Karen. So what advice would you give to those individuals who live in facilities that are placing much higher restrictions on residents than the current IDPH guidance?
I can start, and then
Okay.
is
All
that
right.
okay?
Yeah.
Okay, cool. Basically, here we go again. We tied people down to keep them safe. We gave them psychotropic drugs to keep them safe. We did not do that as punishment. We did it because we thought it was the best thing to do. Times have changed. It's this balance between residents' rights and least restrictive environment, person-centered care, which is really critical and important. So sometimes it's you know, out of concern, the facility doesn't want people coming into the building or mingling and make it a situation where somebody gets sick. So, you know, a lot of the intent comes from a good place, but it's also person-centered. So it is a situation where if there are more restrictions, it's the same as somebody keeping somebody in isolation longer than they need to be. You have to be really careful about that. And the facilities need to work with the residents and with the loved ones and, you know, the family members to ensure that there is that balance between you know, person-centered care, least restrictive environment, and the core components of infection prevention and control. So if you have a facility that is basically saying, no, we aren't going to let anybody in, or we're not going to do this, you know, this is what the state is saying, but we're not going to do that. We're going to go to what they may feel is a higher level of protection. They have to balance that with a resident's rights, you know, to have least restrictive environment. Karen, do you want to?
Yeah, we have said too that individuals could reach out and we can have hopefully a conversation with the facilities. We don't have a problem doing that. Sometimes it's communication. It's always the key to everything, I think. There could be a reason that you may not be aware of if you're unable to visit. You know, the first thing that Deb and I usually ask is, are they an outbreak? You know, what's going on within that facility? We need to take a step back. It's not necessarily that you're not allowed in the building, you per se, it's to visit your loved one, but there could be something else going on that we need to just take a look at the big picture and then balance that. With the outbreak response, we of course have to look at affected unit and unaffected units, and then really determine what activities can and cannot happen. Compassionate care can still happen, end of life visits can still happen, of course. And once if there is an outbreak in the facility, once we determine the extent of that outbreak and what units are involved, if it's only one unit, then other units can resume indoor and outdoor visits. And even the affected unit can still have outdoor units. But what cannot happen is the person that is suspected or confirmed to have COVID, they're not allowed to participate. So they would not be allowed to go outside or go to the common dining areas, things like that. So there are restrictions in place for the safety of the other residents within the building. When you're being denied entry for whatever reason, I would just have a conversation with the administrator to try to get a feel. Obviously, they can't share other information related to other residents, but they can at least tell you if the building is an outbreak, and they should be communicating that and notifying families of that anyway. So just a conversation about that, and then just getting a better understanding of what, or if and when you can visit and what that looks like. So visits should be occurring. If it's not, have a conversation with the administrator and try to get a better perspective of what's going on. And then if not, from there, I guess you could file a complaint and Becky would handle it from her end.
Right.
Hey, thanks. And I would like to just add to the discussion here too, to just let everyone know on the phone that, that frequently it's a collaborative effort here at the department. So we will reach out for Deb and Karen. They have a conversation with the facility to make sure, do they understand what the current guidance is from IDPH, what the current guidance is from the CDC, but that doesn't mean that it stops there. So, if a resident is being denied visitation rights, IDPH can and does go into a facility to investigate. And this is another piece where I think it would be just so helpful that when we do have complaints surrounding visitation rights, that if our surveyors reach out, for the family member or for the resident to assist in that process, to tell them what your experiences are, that's helpful to us as we evaluate whether there's a deficiency in this facility, whether they have not followed the regulations, whether they have not allowed a visit when they should have. So there's a lot of factors that come into play, but I didn't want you to think that the buck kind of stops with telling the facility or asking the facility what the practice is. The more we communicate with each other, whether that be with you and the facility administrators, with the Department of Public Health, with the Ombudsman, with our infection control experts, and with us here at the department when it comes to regulations and potential violations, the better we will be, the better system we will build. We also, as Deb said, meet with providers frequently to discuss what the current guidance is and what the current situation is. That's an ongoing dialogue that occurred with regularity during the height of the pandemic, but still occurs on many different levels. This communication is just so essential. And thank you. Thanks, Kelly, Deb.
Sure. Yes. Thank you.
Kelly, this is Karen. Can I add one more thing to that? Only because I feel like it's still in the same line of questioning, so to speak. One of the things that I have received calls from loved ones on is the fact that they are wanting to come in and stay maybe several hours to visit their loved one. Maybe they've always sat at the bedside, et cetera, with their resident, and they're now being asked by facilities to perhaps leave, or because they're in a 2-bedroom, for example, the other resident's family would like to come in and visit, and only one person can be in the room at a time. That is an IDPH guidance. It's actually CMS guidance that says that really you're only wanting one, I'll say family, one visitor and group in a room at a time. And the rationale for that is, again, think of it's a small space and you've got you're having two different mixed groups. Even though you may have the curtain drawn, you're still sort of commingling in a very small area. And we're trying to prevent transmission. Again, we don't know where the loved ones have been. Even if they're vaccinated, we still don't know where the family members that are coming into the building have been. And so we're trying to, it's a safety issue. And so CMS clearly has said that all attempts should be made to, not have two visits going on at the same time. What I have shared with others at that time is there any opportunity then that one could go outside, or one, if you've been there for a few minutes, we may not make you leave, but would you mind taking your loved one to the patio, to the common space now, so that the other person can have their visitor in the room? So again, just some courtesy and things, and why that could be happening.
Thank you, Karen. This is some great information that you all are providing. I truly appreciate it. We're having half an hour left, so I'm going to try to get through the next two questions because I really want to take questions from our audience. So let's move on to our next topic. So after being isolated for a year or more, some residents are fearful of resuming activities with others. Bruce, I'm going to give this question to you first. Do you have any advice or suggestions for those residents who are apprehensive about communal dining or group activities?
The only thing I have to say about activities is you're allowed to have activities, and if you're vaccinated, you're allowed to take your mask off and have activities and dining with other people. I recommend you do as many activities as you can to keep up your physical body. And that's about all the comments I have on that.
Okay, thank you, Bruce. Deb or Karen, did you want to make a comment about that topic real quick?
I'd agree with Bruce.
Okay.
Okay.
All right. Thank you.
Remember the core measures that Deb mentioned earlier, hand washing, things like that. Wear your mask, source control. If that makes you feel comfortable, even if you're vaccinated, you always can wear more.
Thanks, Karen. So our last topic is about staffing. So staffing continues to be an issue at many facilities and with many businesses across the country. So Becky, did you want to offer or have any thoughts about staffing shortages in facilities and how that may be resolved?
Hey, Kelly, thank you. And thank you for this question that I know has a lot of interest, from a lot of different perspectives. Staffing in nursing homes and staffing shortages predated the pandemic. We know this. We know that there's staffing shortages across the country when it comes to certified nursing assistants, registered nurses, licensed practical nurses in our long-term care setting. So while it's not something that's new, certainly I think that the pandemic has cast a new light on that. And we know that staffing is directly related to quality of care. We know it's directly related to outcomes for our residents in the long-term care facilities and their quality of life. We know these things. So here in Illinois, the legislature has passed some statutes and authorized the department to write some regulations and rules surrounding staffing ratios. So this is something that the department is very interested in. We've undertaken the task of breathing life into those rules, if you will, to gather more information from our long-term care facilities about the number of nurses that are on duty, the number of CNAs on duty, the number of licensed professional nurses on duty, and also how many there should be on duty. So nothing new here. Again, even before the pandemic, the CMS, which is the Centers for Medicare and Medicaid, also requires facilities to report they call it their payroll-based journal, PBJ for short, which is always easy for me to remember because it reminds me of a PBJ sandwich, right? So passion for the peanut butter and jelly, but that is the nuts and bolts of it, is that facilities are required to report that information. So now they're reporting it to the federal government. They're also reporting it to the state of Illinois, or they will be shortly as we build out the database to accept that information, very similar to what they provide to the Centers for Medicare and Medicaid. The difference for Illinois, besides just reporting the data, is that now under our regulations, we can look at that information and calculate whether or not there was a staffing shortage, and then ultimately find a violation for the facility. So we can impose a money penalty, if you will, is kind of the short version, where there's staffing shortages. So I think that this information is crucial. It's not only just crucial from the perspective of what does the staffing look like in facilities and imposing a violation, but it's important for us to have a really well-defined picture of what staffing looks like in facilities. We do know as a result of the pandemic, there's also been an impact on nursing homes. During the height of the pandemic, the state, the governor's office passed some executive orders, and we passed some emergency rules that allowed certified nursing assistants to return to the workforce without having to pass another certification exam. So we really tried to do everything that we could to increase staffing, knowing that there's a direct relationship to patient care. So this, again, not a new issue, but an issue that I think is really crucial that the Department of Public Health and others look at to see how we can effectuate change in our long-term care facilities, to see how it's possible to not only attract but retain qualified staff in nursing homes. It's crucially important. Of course, we know that there's other agencies, including HFS, that are also interested in staffing in nursing homes and how that translates to quality of care and outcomes for our residents. So I know that's kind of a big overview there and a lot of information to take in. So I hope that answers the question, Kelly. So how can it be resolved? How can staffing shortages be resolved? Through a collective effort. The Department of Public Health isn't going to change that by enforcing a regulation and imposing fines. Facilities can't change it alone. The Ombudsman can't change it alone. HFS can't change it alone. Reporting to the Centers for Medicare and Medicaid can't change it alone. What it takes is a collaborative effort to understand the dynamics and first understand the data. How many residents do we have in the facility? How many skilled healthcare providers do we have? So these are all important to developing a solution for the staffing shortages in the long-term setting.
Yeah.
So, yep.
No, I was just going to say thank you. I appreciate that response. I know that our audience was really interested in hearing a bit about that. So thank you for that. I just want to pivot a bit because I know we got a lot of questions that are coming in, and I want to take the liberty to shift and move to our questions because it's 10:33. So I want to be able to get some of these questions in. Senator Jill Tracy, I see your hand is up. I believe you're unmuted. You want to ask your question? And welcome. Thank you.
Well, yes, thank you. And I do appreciate so much you're having this forum for all of us. And I would encourage more. I know there's so many families out there that have so many questions and have had experiences. And just last Friday, I wrote Dr. Ezeki a letter outlining that the long-term care facilities, while very well intentioned, are not consistently and logically enforcing public health guidelines. And I urged clarification on some of the issues that they seem to err on the side of caution. But I think it's easier to have a complete 100% quarantine when we have residents and staff still testing positive, even after vaccinated, which is so very frustrating as we go forward, seeing this trend now, where they will quarantine the whole facility and say there's 50 units in a long-term care facility, the whole place will be locked down. And what I have observed, because I have a 93-year-old mother in long-term care, is that they were on a 14-day period quarantine, and that was extended because of more positive tests. But rather than quarantine the individuals, the whole place is quarantined. And truthfully, it's just easier to do that. I get that, but not for the residents. And although I really like my facility and no one wants to make a complaint against a facility, however, they're not logically and consistently enforcing these measures. I was not allowed to go into the facility. I had bought one of those tests that you can get now, the Abbott test, thinking that if I tested, showed I was clear, because we're in the middle of a real estate transaction. I need to go through canceled checks and help my mother with her business affairs. They would not recognize the test. But yet I could take my mother to a restaurant outside the facility and bring her back. Now, where's the consistency in quarantining of that? I want them to be more, they do the contact tracing. Why can't they isolate the individuals that are testing positive and the staff that see them to just those things? There's so many things they could do. And this long pandemic has caused everybody to go outside the box, to be more creative and do things to encourage it. But it's just easier to keep everybody out. And the debilitation I see every quarantine, to be in an apartment for 20 days and not have left is so debilitating on these seniors. They're losing their lives. They're losing their hours. And you can just see the downturn when they call you 20 times a day crying. It's really hard. They're so isolated. And so I have urged Dr. Ezeki to clarify and continue these programmings, listen to more people, allow more questions, so you can see that you all are painting a different picture, a good picture, where we're seeing just horrible situations. And I don't like to play up our situations when I've seen so many families lose loved ones during this pandemic. I understand the need for public health safety, but at some point, we have got to allow more risk, I suppose, if you will. And I know the liability factor, I'm an attorney. I get that, but we're killing these seniors, hundreds of them, and taking away hours of their lives by these continual quarantines.
Becky, did you want to, thank you, Senator Tracy, I appreciate your comments. Becky, did you want to respond, or Deb or Karen?
Yeah, this is Karen. I have just a quick comment to that, Senator Tracy. And I don't know that it's the answer, but hopefully it will help that on the new guidance that is getting ready to be released. I'm going to call it a checklist, for lack of a better word. At the end of the guidance, it will say, in an outbreak, do this, 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 and this, and sort of outlines it specifically for facilities, because we do still struggle, or facilities are struggling with what to do when, and trying to navigate and really tease out all the, what I call the paragraph forms, and what's, just tell me what to do. That's what they want to be done. And so we've tried to, in this new guideline, the guidelines that are getting ready to be released, at the back of it will have a checklist per se. And it does allow and does reiterate the point that everybody does not need to be in quarantine. The building does not need to be in quarantine. Determine your affected unit, and then and that should be done within 2 to 3 days, honestly, because we have been saying your lab should be back within 24 to 48 hours. We do ask everybody to pause while they do that facility-wide testing. Once they know that someone's positive, as soon as they get those results back, then they need to make a decision. You either have an affected unit or an unaffected unit, and the unaffected units can go back to life as normal or usual, whatever the right word is there. So hopefully this version will help some of that. And hopefully that's helpful to you.
Thank you. Yeah, go ahead.
More mandate on facilities not doing what Senator Jill Tracy is saying. And I think that's what she's getting to the point at, is facilities are doing what they want to do, and they're not following the rule if there's an outbreak, and then they're holding the whole facility captive.
Thanks, Karen, and thanks, Bruce. And Senator Tracy, thank you so much for the discussion here and sharing your experiences. It is important that we're consistent in our approach. It's important that facilities are consistent. it makes it so challenging, as we all know, when some of the guidance depends on what the outbreak looks like in that community. But here again, I think that's what you're making the point, is that, is there a way for that to be consistent and send that information out to our facilities such that, as Karen mentioned, they can follow a checklist. That I think that will help the situation, but it also will help when we know about those situations, including the one that you described. So that way we can get in, we can investigate, and we can see, can we find a deficiency in this facility? Are they painting everyone with a broad brush when they don't need to? Have they followed the protocol to move residents that are COVID positive to a certain part of the facility, delegate staff to their care? Those are the things that we can do when we go in and investigate. Are they implementing not just the best infection control practices and the ones that they should be, but are they also making sure it's person-centered, and that families and residents in long-term care facilities are not languishing, that we're making sure that their resident rights are protected. So I really appreciate you bringing this to the forefront, and encourage anyone that does have these issues, please to contact us and to speak to our surveyors as well. That's really crucial as we go into facilities, to bring those pieces together, interviewing, and also so that we can observe and that we can look at the records. Those are crucial parts of our investigation.
Thank you, Becky, and Ruth also. Lee, I want to go back and forth because we do have questions in the chat, and we also have some hands raised. So Lee, do you want to pull a question from the chat to ask our panelists?
Yes, we are getting a lot of questions and even some comments, but I will go ahead and start with some of the quicker questions to answer. One of the questions is, what is the CNA to resident ratio? And then there's another question similar that says, what is the Illinois regulation for nurse to patient ratio?
And that question, yeah, okay. I was going to say, Becky, yeah, answer that. Okay.
I can. It will take a little bit of a deeper dive into our regulations. So our regulations do kind of to shore up the answer without giving the percentages. In our regulations, Illinois Code of Regulations, it does provide that the facility gives us a census that says these are the number of residents that we have in skilled care. These are the number of residents that we have in intermediate care. And then we look at that and we say, well, in order to care for those patients properly, this is how many nurses you have to have, and this is how many CNAs you have to have. It's kind of the short answer to that. So when we look at the facilities data and we see that they submit to us that says, here's what our staffing looked like for that day, and here's how many patients or residents we had in these type of care, we can see, did they have a shortage? And if they had a shortage, the regulations allow the Department of Public Health then to say, if you were short X number of hours, we're going to multiply that by what the average wage is for a certified nursing assistant, according to the Bureau of Labor Statistics, or what the average wage is for a registered nurse. And that will impose the fine on the nursing facility. So the facility is, providers are allowed certain parts of their staff to account for direct care. Those are the things that we take into consideration. How many hours of direct care can the facility provide through their staff? And then we'll translate that into, does that meet what the minimum threshold should be? I know that doesn't give you the exact specifics. I'm happy to look at those specific numbers and provide that back to Kelly or to anyone in the chat if they're looking for the exact numbers and the references, what those look like. But that's kind of in a nutshell how that's calculated.
Thank you, Becky.
You're
Lee,
welcome.
Lee, I have a question in the chat that I want to ask of IDPH, and then I'll kick it back to you.
Mm-hmm.
So one of the questions that came to me was, what's on the horizon with IDPH to improve infection control in facilities and quality of life for residents?
That's a great question. With regard to infection control, the department undertook a couple of initiatives. One was training. So the Centers for Medicare and Medicaid mandated that employees in long-term care facilities have training around specifically COVID and infection control practices. So we have in turn sent out attestations, or we're requiring facilities to say, yes, we had this training. Our surveyors are going in, they're looking for that training, they're looking for proof of that training when they go into facilities. We also have many improvements, I think, to our rules and regulations. They are currently under consideration by our advisory board, and then they will move out of that process to another body that looks at those rules and takes additional feedback from residents, from family members, from others, from all stakeholders to look and see, you know, are these rules, are they good rules? We have had our infection control preventionist, Deb, Karen, Dr. Kennard working with us on those rules. We've turned to guidance from the Centers for Disease Control, also from the Centers for Medicare and Medicaid, to really develop stronger infection control practices and principles in long-term care facilities. So we are very interested in that. I can also tell you that, you know, as we see the deficiencies cited in nursing homes, especially during the pandemic, there were a lot of deficiencies surrounding infection control. There was a lot of room for improvement there in practices. The department was very aggressive about doing focused infection control surveys. We partnered with our federal partners at the Centers for Medicare and Medicaid, and we were in facilities for very extended periods of time. Our infection control experts on the call here too, Deb and Karen, worked with facilities to bring about more robust infection control practices. We know how crucial that is in the long-term care setting. And again, I will tell you that those deficiencies, many of them existed prior to the pandemic. But then of course, during the pandemic where we have COVID, you know, they're all the more crucial. So I think it really casts light on the importance of infection control, good infection control practices in nursing homes. And we will do our part here at the Department of Public Health from a variety of perspectives to make sure that occurs with regard to infection control. And you had one other question. It wasn't just infection. There was another one.
In quality of life of the resident.
Quality of life for residents. So one of the things that the department is definitely interested in is improving the quality of care and quality of life. So of our residents, we know that as a regulatory agency, you know, we can go out, we can survey, we can seek to ensure that facilities are in compliance with those factors that affect the quality of life and quality of care. But it doesn't stop there. You know, much like the staffing ratios, we need to do more, right? So imposing fines on facilities and violations, yes, that has an effect, but we need to do more than just impose fines. We need to bring parties together, as we've talked, Kelly, all of our experts to the table to see what do we do to improve quality of care, quality of life. As you know, we're working on funds that will be distributed to facilities, to the ombudsman, that propose projects that specifically address the quality of care and quality of life. How can we improve that? The department is very interested in that and bringing a dialogue to the table, much like the one here with other parties. So definitely on the department's radar, we can look at facilities and know what deficiencies they have that really impact quality of care and quality of life. And then I think we have to come together to figure out how do we move that. If violations aren't enough, penalties aren't enough, how do we collaborate to move that?
Thank you for that response, Becky. Lee, I see a couple of hands raised. I believe a resident has her hand raised. So I'll bounce it over to you and let you unmute whomever you want.
Before I go ahead and I start collecting hands, there are people that have been asking questions in the box. So I would like to respect those questions that they've been asking in the chat box. So one of the things there are, Becky, there are a lot of questions around this regulatory issue because I think people don't quite have the understanding about how the survey process works. So I'm not to put you on the spot, but there was just a comment, this being in the spirit of a true town hall meeting, just to share some feedback. And one of the questions was that was more of probably more of a hypothetical question, but just food for thought. How many residents are involved in the development of the IDPH guidelines? They are the people who are most impacted by it. Their input is important. So just food for thought. But then there's other ones that when surveyors go into a facility as a result of a complaint, do they look at things outside of that complaint? And has IDPH actually cited in the facilities for not allowing visitation or enough visitation?
Thanks, Lee, and thanks for those questions from our residents and family members on the phone. With regard to resident input and feedback, that is so important to the department. It truly is. We've been working with Kelly and with others to fill vacancies on our long-term care advisory board, where we're looking for a member of that board that comes from a resident council. So that position has been vacant for a while. And every time I talk to Kelly, I think I lean on her to say, we need someone on this board because it is so important to have the resident voices. And as IDPH is moving forward with several initiatives, we recognize having resident feedback on how we improve quality of care and quality of life is so crucial. And I also know to our representatives and our senators that have joined us on the call, they too have held meetings to hear feedback from residents. And that is just so vitally important as we contemplate, how do we shift our regulations. We take guidance, of course, from the legislature on how we do that and changes to the statute. So I think, once again, it really, yes, having that resident input is so crucial. And I know we're all wanting that input in a variety of forums. And Kelly, again, remind you, whatever you can do to help us fill that space on our advisory board, we would be so grateful. We have several vacancies on that board, but especially the resident council. And then with regard to the survey process, I think the question was, do they look at other information when they go into a survey? I believe, was that the question, Lee?
Yes, it was.
Yes, of course we do. We do. So again, our ombudsman, our partners in the long-term care setting, and our ombudsmen are frequently the eyes and the ears, the advocates of residents. We have regular calls. So we do listen to what feedback the ombudsman is providing to us and what they see on behalf of the residents. When our surveyors go into a facility, they don't limit the questions just to one resident. They would take a sample, if you will, of residents to see and to hear, through that process, what's going on in a facility. They would speak to numerous staff members, not just one, but multiple. So when we see what we call a statement of deficiencies, where we have found that the facility is not in compliance with the rules and regulations, we will see in that statement that, and they don't identify who the resident is, it's anonymous, but they would say when they interviewed this resident, this is what information they provided. For example, if they weren't allowed privacy with regard to their visitation, this resident complained about that, or this was the facts. And another resident, if that resident said the same thing, they would interview that. They would interview the staff to say, okay, not just one certified nursing assistant, but others on other shifts. What did they have to say? So they do expand. I can see you're waving. I'll shut up here to give you time, but they do expand that investigation to others. I'm gonna shut it off here because I see other residents waving.
Right, waving.
Yeah.
All right, Lee, you want to take it? Thank you, Becky.
Yes, I will. I do see somebody that seems like they have an urgent question, and I'm asking you to unmute. That's Applewood Activities.
Can you unmute yourself? Lee, I know, you know what, she's also put a message in the chat I got from Applewood Activities. The question was, they're shorthanded CNAs, and is it true that they're going to get another shot?
Okay.
That was one of the questions that I got.
Say something.
Okay, my question
okay.
is, my name is Monica Giles. I'm the resident council president for Applewood. And I've been hearing on the news that we're supposed to be getting another shot. And I feel sorry for the CNAs that gotta work shorthanded. And, you know, like I say, I've been here 11 years. It's a great nursing home and all, but it's just that, you know, I don't know what's gonna be happening, because I had a friend that came to visit me a couple weeks ago, and they told her that she had to make an appointment. And they, you know, the one girl at the desk said that she had to leave, she had to make an appointment, and she didn't know that.
So Deborah, Karen, did you want to speak to Monica's question?
Hi, Monica. Thank you very much. You know, for saying it. It sounds like you've got two different questions there. And the
Yeah.
first one has to, here, let me put my camera on. The first one has to do with, are you going to need a booster shot? Are people going to need
Yeah.
a booster shot?
Yeah.
They're working on that right now. If I had to guess, and it's just an educated guess, we might end up, you know, like you get an annual flu shot, it may be a situation down the road. It'll depend on what the Food and Drug Administration decide. Some of the
Okay.
companies are doing research right now, you know, that this is actually a 20-year-old technology with this type of vaccine, but they're
Right.
learning, and it may also depend on how the virus changes. You know, if it changes again, right now it looks like we've got pretty good coverage with what's floating around, but
Okay.
if it changes again, we may have to. So stay tuned on that one. And the second one is staffing. Yeah, staffing is a big challenge. I hear you. I definitely hear you. And coming from somebody who worked as a CNA for 15 years, I get it.
Yeah, so do I, because I was a CNA for 15 years. But the only thing that I'm saying is, I feel sorry for these girls, because they got, you know, it's like they got double work to do. And then, you know, I get where they're coming from, you know. And the activity department is the best, you know, they try and do the best they can with us, you know, and they're good. And like I say, I've been here for 11 years. When I first came here, I couldn't walk. And I have many medical issues that go along with me. But, you know, if I had I wouldn't go anywhere else, you know, because the nurses are good. The ADON and DON are the greatest. Stephanie and Janine, they're the best.
That's really wonderful that you're feeling like you really do enjoy the place that you're living at, because this is your home. So
Yeah.
we're thrilled to have residents on this call, as this is a resident town hall meeting. So we really do appreciate all the people that have been on. We actually are nearing the end of our hour, so I would like to be able to just address some of the things that have been commented on in the chat. And just some of the things, again, being in the true spirit of this being a town hall, some of these are really not for answers. And it's just to make sure that it makes us aware, because not everybody on this call does come from are living in a long-term care community. And I think or have somebody they love in a long-term care community. I think it's important that people understand how this feels to people that live there. So this is just a quick story that was just shared. My brother is in a DeKalb nursing home, and we fought to have him out for visits to our brother's house. He's been vaccinated as well as my brother and his wife. Every time, like now, when an unvaccinated staff bring in COVID, they lock down and can't leave the rooms or go for outside visits. Can't they leave their rooms or go outside for visits? Can they infringe on residents' rights? He says he feels like he's walking out, but he's a diabetic and only 56-year-old and he needs his medicine. It seems that they cater to staff and take away residents' rights. And that was actually commented on it throughout a couple of times throughout this, but I feel that this is something maybe that Deb and Karen could just comment on regarding the infection control and the need for that.
And I direct message that person. I will follow up after. When the thing that Karen talked about early, and an advantage that we've got going now is that we all of the different departments are working very closely together. So I will follow up right after this call. This is the type of thing that Karen was referring to, that we can collaborate and get more information. And then if need be, we can involve healthcare regulations as well. We're all working as a team.
Yeah.
Wonderful.
Thank you, Deb. And Lee, it's actually 1 minute after 11, so we've reached our hour. This has been an amazing discussion, and I hate that we don't have more time. What I intend to do is to take the information that we've gotten in terms of the questions in the chat and see if we can get some of these questions answered and post them on our Facebook page. I thank my panel members for their participation and willingness to join in this discussion, and the interesting discussion that we had and all the questions that have been posed to us. And we will actually have another one in the near future. I'm overwhelmed by the participation, and I'm just so thankful that we had the opportunity to bring this to everyone. So I just want to thank everyone. Lee is about to put up a poll real quick with just only 2 questions. I had mentioned that earlier. If you all could take the time to answer these 2 questions before we adjourn.
And if you have not put your zip code into the chat box, we would appreciate that. We're tracking areas in the state that we've been able to have people participate in. Thank you.
Thank you, everyone. Thank you, Lee, and thank you, Deb and Karen and Bruce and Becky.
Thank you. Thanks,
Thank
Kelly.
All right.
Thank you.
Bye.
Bye-bye.